Next, I'm going to introduce Dr. Dubreuil. She's a rheumatologist who focuses her research on the comorbidities and pharmacoepidemiology of spondyloarthritis in order to inform both clinical care and policy decision-making. She's at the Boston University School of Medicine, and we're delighted to have her here to talk about her Arthritis Foundation funded DEI program. So I'm going to turn it over to her next.
Thank you so much for the kind introduction, Maria. So I'll be presenting on this study, Delay in Diagnosis of Ankylosing Spondylitis, Do Race, Ethnicity, or Social Determinants of Health Matter? So just to set the background in terms of ankylosing spondylitis, next please. This is a condition that's an inflammatory arthritis of the spine, and the key area that's affected and reviewed at the time of diagnosis is in the pelvis, involving the sacroiliac joints. What's shown in the left here is a normal pelvis x-ray, but then in the middle shows signs of sacroiliitis. And so this helps a clinician to diagnose ankylosing spondylitis in their patient. If a person has ankylosing spondylitis for many years, they often have involvement outside of the pelvis, including other areas of the spine. And so that's what's shown on the right x-ray here. So what we've known in the last 3 decades is that permanent x-ray changes take several years to develop, but we can actually identify people who have axial spondyloarthritis, the broader family that includes ankylosing spondylitis. We can identify people with that condition using MRI. And what's shown in the left image now is an MRI, which shows inflammation of the bone and inflammation in the sacroiliac joints. These people can also be identified with elevated inflammatory markers in the blood, and often will have other associated conditions. So ankylosing spondylitis, as I mentioned, involves primarily the spine and sacroiliac joints, but can also involve nearly any joint in the body. And so that includes peripheral joints in the arms and legs, and it can also include the tendons, which are shown here as enthesitis, inflammation at the site where a tendon attaches to bone. Outside of the musculoskeletal system, the condition can also involve the skin by causing psoriasis. It can involve the eyes, causing a condition called uveitis, and inflammation in the bowel can be Crohn's disease or ulcerative colitis. Now, thinking about ankylosing spondylitis, the primary symptom is back pain. And so it's important to think about disparities in back pain management that exist. We can think about the journey as a person with back pain seeks healthcare, initially from their frontline healthcare provider, and some potential barriers in that journey that might disproportionately keep some people from accessing or seeking care. So as some examples, there are differences in pain beliefs or the pain experience that may prevent some people from accessing care. There are issues around access related to insurance, or related to social support systems, such as dependent care or transportation. And then the third bullet that was listed there is around mistrust of the healthcare system, particularly subgroups of Americans who may have been subjected to unethical medical or research practices or even racist practices in the past. If we think then about the second leg of this journey from a person who must be referred from their frontline healthcare provider to rheumatologist, typically for diagnosis, there are other issues that might, again, disproportionately keep some people from obtaining a diagnosis of ankylosing spondylitis or from treatment. As one example, frontline healthcare providers may have outdated knowledge about ankylosing spondylitis. They may believe that this disease only affects young white men, and they may fail to consider the diagnosis among people from other subgroups. There may be an incomplete evaluation for back pain, and we know that in the United States, African Americans and Latinx individuals are less likely to be referred for advanced imaging. They're less likely to be referred to a specialist in the setting of back pain. And then thirdly listed here is lack of access to rheumatologists. We know that people who live a greater distance from a rheumatologist are less likely to receive rheumatologic care, and about the maldistribution of rheumatologists, with a greater proportion of rheumatologists on the coast relative to the center of the US. So as Dr. Chun mentioned, we also have a challenge of outdated education around ankylosing spondylitis And this is one of the historic issues that many images in ankylosing spondylitis feature Caucasian people and feature men. And so it's important, and outside of this project, we have many educational initiatives ongoing to provide frontline healthcare providers updated knowledge that ankylosing spondylitis occurs in all genders and all demographic groups. One other challenge in ankylosing spondylitis is around classification criteria. And these are over a decade old, but they are still in use and in the process of being revised. These criteria are applied to a person who is being considered for enrollment in a research study, and they must meet these criteria to be involved in research. And the issue is around the genetic criterion for establishing a diagnosis. You can see there are two arms to this criteria. On the left in the gray box is sacroiliitis on imaging. And so people from all backgrounds are eligible for that. On the right, what we see is a gene termed HLA-B27. And this gene tends to be more common in people who are European ancestry or Asian ancestry, and less common among people from other ancestries. So next, please, if we continue to apply this type of criteria, we are making it much more difficult for people of non-Eurasian ancestry to be enrolled in research. And these classification criteria also have an impact on clinical diagnosis as well. So our study question is the time from back pain diagnosis, back pain onset to the time of ankylosing spondylitis diagnosis different based on individuals' characteristics? And we had particular interest around gender, age, race, ethnicity, and social determinants of health, which I will go into. To do the study, we used data from Boston Medical Center's electronic health record. We are the largest safety net hospital in New England, and more than half of the patients are below or at the poverty level. We also see a very racially and ethnically diverse population, including over a third who are African American and over a quarter who are Hispanic or Latinx. In terms of social determinants of health, we have a very unique process to administer a questionnaire in the primary care clinics of all of our adult patients and assess things like food and housing insecurity. So we considered 4 of the questions from this questionnaire in designing our current study. Those are listed here, the top 2 addressing housing insecurity and the bottom 2 addressing food insecurity. And we considered that if a person ever answered yes to any of these 4 questions, they were considered to be at risk, have a social risk factor. There were other questions, other items on the questionnaire that we did not consider as part of this study around security in transportation, paying for utilities, paying for dependent care, or paying for medications. So in terms of our methods, we included adults who had a diagnosis of ankylosing spondylitis in the last 20 years. We required prior to that diagnosis that they had at least 1 outpatient visit in our system. And we required a diagnosis of back pain or another AS-related condition before the AS diagnosis. Next. We assessed recorded data on several other individual characteristics as well. That includes age, gender, race, ethnicity, and the social determinant of health questionnaire I just showed you. The primary study outcome was time in months from the initial back pain diagnosis to the diagnosis of ankylosing spondylitis. We also considered a secondary study outcome from their first AS-related condition, be that tendonitis or arthritis, psoriasis, uveitis, or IBD, to the diagnosis of AS. So in terms of study methods, we leveraged a unique way of programming the data, addressing a common data model. And so this describes the way that the electronic health data is structured. We first identified the criteria for our cohort of interest based on their diagnoses and visit requirements. Our programmer then built concept sets to represent those features and built the final cohort. I evaluated the cohort using participant profiles and then performed some refinement. And finally, our statistical analyst carried out that plan. What I do want to mention about this is that the programming, I said, is quite unique and strong in that after performing the study within our own hospital data, We can use the same programming at other institutions whose data is formatted in the same common data model. We were able to include 404 people who have ankylosing spondylitis. The mean age was 49 years. 61% were male. You can see around 40% were white, 26% Black, around 14% were Hispanic or Latinx, and over a third reported having a social risk factor. In terms of ankylosing spondylitis characteristics, you can see over a third were on treatment with usual medications, including non-steroidal anti-inflammatory drugs, TNF inhibitor, or steroid. Next, please. In terms of testing within the previous year, the year previous to diagnosis, 7% had inflammatory markers, 17% had the gene tested, and over 81% had spinal imaging. And then in terms of healthcare utilization, around a quarter had a visit with primary care provider or a rheumatologist. So the preliminary results are shown here, and these show months delay in diagnosis related to the risk factor shown. So click, please. This top row shows that if a person ever had the social risk factor of interest, their diagnosis of ankylosing spondylitis was delayed by 19 to 20 months. Next. Per year of age, diagnosis was delayed by 0.8 to 0.9 months. Females' diagnosis was delayed by 10 months. Black individuals' diagnosis was delayed by a year. And lastly, Hispanic or Latinx individuals' diagnosis was delayed by 11 months. And this last one did not achieve statistical significance. So in summary, there was a 1.5 year delay in time to AS diagnosis among people who had housing or food insecurity. And there was nearly a year delay in time to AS diagnosis among people who were women, African American, or Hispanic or Latinx. So we have still much work to do. These are preliminary results. We have planned and in the works a more sophisticated analysis that allows us to account for all of these variables of interest in a more accurate way. We will explore the potential reasons for delay by looking at testing that was done, blood work and imaging, looking at medications that might kind of mask pain, looking at referrals to other specialists for back pain management, and assessing whether back pain management is consistent with published guidelines. We will also, following this award, hope to branch out to another healthcare system and leverage, as I said, this innovative programming approach. And then we hope to develop interventions for the aspect of care that cause disparities in time to AS diagnosis. So a big thanks to the study team that made this possible, but an even bigger thanks to Arthritis Foundation for recognizing the importance of this type of research.
Thank you very much, Dr. Dubreuil. And you already mentioned some of your plans about potential expansion of the work and making it multi-institutional, but perhaps you can comment on the connection between some of the research findings, because this is an example of one of the projects that we've funded in the research initiative space, and the needed recommendations for steps that can be taken to address some of the disparities of both access and just trying to find solutions. Do you have any comments that you might want to make in terms of where you think some additional work might be done to take advantage of some of your findings?
Yes, I think there are many approaches. So as we've already heard, diversifying the rheumatology workforce is quite important. Providing education to non-rheumatologists about the spectrum of ankylosing spondylitis and the family of diseases and its occurrence, beyond people of Eurasian ancestry. And then thirdly, exploring the structures that result in these delays in diagnosis.
Wonderful. Thank you very much. And then thank you for this great presentation.